What if I told you there's a disease so rare that it affects only 4 to 11 people per 100,000, but when it strikes in the ICU, it has a mortality rate exceeding 50% if you delay treatment by even hours? Addison's disease, primary adrenal insufficiency, is the great masquerader that can look like sepsis, dehydration, or psychiatric illness until your patient's goes into adrenal crisis and dies. And here's the terrifying part. The symptoms are so non-specific that the average diagnosis takes months, but in the ICU, you have minutes to recognize it. My name is Neil Brian Galvin and this is Nurse Brain, where we give you the confidence to succeed in critical care by breaking down complex topics that can literally save lives. If you want to be the nurse who catches the zebra diagnosis that everyone else misses, make sure you subscribe and hit that bell icon right now. Here's what most healthcare professionals don't understand about Addison's disease. It's not just about low cortisol. This is a complete failure of your patient's stress response system. When healthy people get sick, their adrenal glands pump out cortisol to help them survive. But Addison's patients, their adrenal glands are destroyed. No cortisol, no aldosterone, no survival mechanism. In this lesson, I'm going to show you how to recognize Addison's disease before it becomes adrenal crisis. First, I'll break down the pathophysiology so you understand why these patients crash so hard and so fast. Then, I'll walk you through the subtle early signs that separate this from other conditions. Finally, I'll give you the nursing assessment and management strategies that can mean the difference between your patient walking out of the hospital or not surviving the shift. But first, let me tell you about a patient presentation that should make every ICU nurse's blood run cold. Picture this scenario. A 35-year-old woman comes to your ICU with what looks like gastroenteritis, nausea, vomiting, abdominal pain, weakness. But there's something off. She's hypotensive despite fluid resuscitation. Her sodium is low. Her potassium is high. She seems confused and withdrawn. Everyone's thinking sepsis, but the cultures are negative. Then she crashes into refractory shock and nothing you do helps. That's Addison's disease progressing to adrenal crisis, and it happens because of complete adrenal cortex destruction. Let me break down what's actually happening in your patient's body. The adrenal cortex produces three critical types of hormones: glucocorticoids like cortisol, mineralocorticoids like aldosterone, and androgens. In Addison's disease, autoimmune destruction, which accounts for 80% of cases in developed countries, wipes out all three. First, the cortisol deficiency. Cortisol is your body's natural steroid. It maintains blood pressure, regulates blood sugar, and controls inflammation. Without it, your patients can't respond to stress. Any illness, surgery, or trauma that would normally trigger a cortisol response instead triggers cardiovascular collapse. Second, the aldosterone deficiency. Aldosterone controls sodium and potassium balance. Without it, your patient loses sodium and retains potassium. They become hyponatremic and hyperkalemic. But here's the deadly part. They also become volume depleted because they can't retain sodium and water. Third, the androgen deficiency. This affects energy levels and contributes to that profound weakness and fatigue that these patients experience. But here's what makes Addison's disease so dangerous in the ICU. It's the perfect storm of pathophysiology. Your patient is volume depleted from salt wasting, but they also have no cortisol to maintain vascular tone. They're hypoglycemic because cortisol is needed for glucogenesis. They're acidotic because of the hyperkalemia and poor perfusion. And here's the part that kills patients. When these patients get stressed by illness, surgery, or trauma, their bodies can't mount the normal cortisol response. A healthy person might increase their cortisol production tenfold during stress. Addison's patients, zero increase. That's why they go from stable to dead so quickly. Now, let's talk about how Addison's disease actually presents, because this is where most healthcare providers get fooled. The chronic symptoms are so non-specific that patients often get misdiagnosed with depression, chronic fatigue, or eating disorders for months before anyone figures figures it out. The classic chronic presentation: progressive fatigue and weakness, but not just tired. We're talking about profound exhaustion that doesn't improve with rest, weight loss despite normal appetite, hyperpigmentation, and this is key, especially in sun-exposed areas, skin creases and mucous membranes. This happens because ACTH levels are sky high, trying to stimulate the destroyed adrenal glands, and ACTH shares a precursor with melanocyte stimulating hormone. But here's what you need to recognize in the ICU: the acute presentation of adrenal crisis. This is a medical emergency with mortality rates of 50% or higher if treatment is delayed. Cardiovascular collapse: profound hypotension that doesn't respond to fluids or pressors. Why? Because without cortisol, blood vessels can't maintain tone, and without aldosterone, their volume depleted from salt wasting. Electrolyte chaos: hyponatremia, often severe, less than 130. Hyperkalemia, sometimes life-threatening levels over 6. Hypoglycemia, because cortisol is needed for glucose production. Gastrointestinal symptoms: severe nausea, vomiting, abdominal pain that can mimic an acute abdomen. Diarrhea leading to further volume depletion. Neurological changes: confusion, agitation, or decreased level of consciousness. This isn't just from hypotension, it's from the electrolyte imbalances and hypoglycemia. But here's what makes recognition so challenging: adrenal crisis can be triggered by any stressor: infection, surgery, trauma, even emotional stress, and the symptoms overlap with sepsis, dehydration, and other critical illnesses. However, there are some key distinguishing features that should make you think Addison's disease. First, the hyperpigmentation. If you see a patient with unexplained darkening of the skin, especially increases in mucous membranes, think adrenal insufficiency. Second, the electrolyte pattern. Hyponatremia with hyperkalemia is classic. Third, hypotension that's out of proportion to the apparent illness severity. And here's a clinical pearl that could save a life: any patient with history of autoimmune diseases like type 1 diabetes, thyroid disorders, or vitiligo who presents with unexplained hypotension and electrolyte abnormalities should make you think polyglandular autoimmune syndrome with adrenal involvement. Alright, so you suspect Addison's disease. Now what? The diagnostic approach in the ICU has to be fast and focused because you can't wait days for confirmatory testing when your patient is in adrenal crisis. Your immediate laboratory workup should include basic metabolic panel, looking for that classic hyponatremia and hyperkalemia. Complete blood count. You might see eosinophilia, which is unusual in critically ill patients and should raise suspicion. Arterial blood gas, looking for metabolic acidosis. Random cortisol level, but here's the catch: a normal cortisol doesn't rule out adrenal insufficiency if it's not appropriately elevated for the degree of stress. The gold standard test is the ACTH stimulation test, but here's the critical point: you cannot wait for the test if you suspect adrenal crisis. The test involves giving synthetic ACTH and measuring cortisol response. Normal response is cortisol rising to at least 18 to 20 micrograms per deciliter. In Addison's disease, there's little to no response because the adrenal glands are destroyed. But in adrenal crisis, you treat first and test later. Draw your blood samples for cortisol and ACTH levels, but don't delay treatment waiting for results. Other supportive findings: elevated ACTH levels, often 10 times normal because the pituitary is trying desperately to stimulate destroyed adrenal glands. Low aldosterone with elevated plasma renin activity. This confirms mineralocorticoids deficiency. Anti-adrenal antibodies, specifically 21-hydroxylase antibodies in autoimmune cases. Imaging can be helpful. CT scan of the abdomen might show small atrophic adrenal glands and autoimmune disease, or enlarged glands if there's infiltrated disease like tuberculosis or malignancy. Chest X-ray might show a small heart due to chronic volume depletion. But here's what you need to understand: the diagnosis of Addison's disease in the ICU is often clinical. If you have a patient with unexplained hypotension, hyponatremia, hyperkalemia, and hypoglycemia. Who's not responding to standard treatment, you need to consider adrenal insufficiency and treat empirically. The good news is that the treatment is straightforward and can be life-saving when given promptly, but delay treatment while chasing other diagnoses and you could lose your patient to something that's completely treatable. Now, let's talk about treatment because this is where you can literally save your patient's life with the right approach and the right timing. For the adrenal crisis, you have three immediate priorities: fluid resuscitation, hormone replacement, and treating the underlying trigger, and the order matters. First, aggressive fluid resuscitation. These patients are profoundly volume depleted from salt wasting. Start with normal saline, 1 to 2 liters rapidly, then continue based on response. But here's the key. Add dextrose because these patients are often hypoglycemic from cortisol deficiency. Second, immediate steroid replacement. Hydrocortisone 100 mg IV push, then 50 to 100 mg every 6 to 8 hours. Don't wait for lab confirmation. If you suspect adrenal crisis, give steroids immediately. The stress of the hydrocortisone also has mineralocorticoid activity, so you don't need separate fludrocortisone in the acute phase. Third, identify and treat the precipitating cause: infection, trauma, surgery, medication, non-compliance. Whatever triggered the crisis needs to be addressed simultaneously. Your nursing assessment and monitoring is critical. You're watching for response to treatment, blood pressure, stabilization, improvement in mental status, correction of electrolyte abnormalities. Monitor intake and output closely because these patients can swing from volume depletion to fluid overload as their hormone levels normalize. Electrolyte monitoring is essential. As you replace steroids, sodium levels should normalize and potassium should come down, but watch for overcorrection. Rapid changes in sodium can cause central pointine myelinolysis. Vital sign monitoring takes on special significance. Temperature. Watch for fever indicating infection. Blood pressure should improve with fluid and steroid replacement. Heart rate should decrease as volume status improves. But if they're not responding appropriately, consider other causes or inadequate steroid dosing. Patient and family education is crucial because most of these patients will need lifelong hormone replacement. They need to understand sick day rules, doubling their steroid dose during illness, stress, or surgery. They need medical alert bracelets. They need to carry emergency hydrocortisone for injection. And here's something that will make you better nurse. These patients often have other autoimmune conditions. Check for diabetes, thyroid disease, and other endocrine disorders. This is often part of polyglandular autoimmune syndrome, so comprehensive assessment is important. Let me talk briefly about prevention and long-term management because understanding this will help you provide better care and education for these patients. The key to preventing adrenal crisis is education and preparation. Patients need to understand that any stress, illness, surgery, trauma, even dental procedures requires increased steroid dosing. The general rule is to double the dose during minor illness and seek medical attention for major illness or inability to take oral medications. Chronic management involves daily hydrocortisone replacement, usually 15 to 25 milligrams daily, divided into 2 to 3 doses, with the largest dose in the morning to mimic natural cortisol rhythm. Fludrocortisone for mineralocorticoid replacement, 0.05 to 0.2 milligrams daily. Regular monitoring of electrolytes, blood pressure, and clinical response. But here's what's critical for ICU nurses to understand. Any patient with known Addison's disease who comes to the ICU needs immediate stress dose steroids, regardless of their presenting complaint. Don't wait to see if they need it. The risk of undertreating far outweighs the risk of overtreatment in the acute setting. Let me wrap this up with the key points that could save your patient's life. Number 1, Addison's disease is rare, but adrenal crisis is deadly. Mortality exceeds 50% with delayed treatment, but it's completely reversible with early recognition and appropriate therapy. Number 2, the classic triad is hypotension, hyponatremia, and hyperkalemia. In a patient who's not responding to standard treatment, add hyperpigmentation, and you should be thinking Addison's disease. Number 3, don't wait for confirmatory testing in suspected adrenal crisis. Draw your labs, but start treatment immediately with IV fluids, dextrose, and stress dose hydrocortisone. Number 4. Any stress can trigger adrenal crisis in these patients. Infection, surgery, trauma, even emotional stress can be life-threatening without appropriate steroid coverage. Here's what I want you to remember. Addison's disease is the great masquerader, but it has a signature. Learn to recognize the signature, and you'll catch the diagnosis that others miss. You now understand the pathophysiology that makes adrenal crisis so deadly. You know the clinical presentation that should raise your suspicion, and you have the treatment approach that can save lives when applied quickly and appropriately. The knowledge makes you the nurse who doesn't just treat the obvious. You recognize the zebra diagnosis that can kill if missed. If this lesson helped you understand Addison's disease and adrenal crisis, hit that like button. It helps other nurses find this potentially life-saving content. Share this with any nurse who needs to master rare but deadly endocrine emergencies. Make sure you subscribe for more critical care education that will make you the nurse who catches what others miss. And check out my lesson on shock recognition that I'm linking right here. It perfectly complements the cardiovascular collapse we see in adrenal crisis. As always, thank you for watching. And remember, in the world of rare diseases, knowledge is the difference between life and death. I'll see you in the next lesson. Once again, this is Nurse Brain, inspiring greatness one lesson at a time.